the words health and care should be separated. You often see it as one word. And we philosophically felt that it should be separated because at a societal level, there's too much of an emphasis on reactive sick care and not enough on proactive health. And so it was our desire to move upstream towards health as a company. But then that same philosophy then cascaded down to all of our programs and services for our associates and their families.
Welcome to Broken Benefits. I'm your host, Lee Lewis, and this is a podcast where we learn from top employer experts on how to fix our broken benefits. Hello, everyone. Welcome back to Broken Benefits. I am your host, Lee Lewis, and today's guest is Arielle Bogorad. So excited to be able to visit with her. Arielle ran benefits at Cerner Corporation for over a decade. She's one of the few employers in the country who was self-administered. I mean, she and her team and her employer paid all of their own medical claims. She has experience with direct contracting and advocating for totally new strategies and solutions, whether it be tactics in social determinants of health before, in the middle of sort of the 2010s, before it was quite as common as it is today, as well as pioneering numerous new strategies. Let's get into it. Arielle, welcome to the show.
Awesome, Lee. Thank you so much for having me. Excited to be here with you.
Yeah, totally.
Yes.
Oh, our pleasure. I wanted to sort of start out, you really have done so many interesting things. And I want to get kind of the story and everything like that. And I think maybe it might be interesting. You could tell us a little bit about your background and some of the ways it might be unique that maybe caused you to approach healthcare in some different ways.
Awesome. Yeah, sure. So a little bit about me. I went to the University of Michigan, go Blue. I majored in organizational studies, which is an interdisciplinary major. And with a passion for population health that I've had from the start, I then went to work for Accenture in their health and life sciences practice, which at the time was made up of three practice areas: payer, provider, and pharma. I was aligned to the payer side, and my first client was Health Alliance Plan, which is a payer in Southeastern Michigan, and also a subsidiary of Henry Ford Health System. It was there that I literally learned about managed care from the bottom up. I sat in 2/3 of the departments of HAP to determine how we can make them more effective and more efficient. I was like Bob in Office Space, except instead of them coming into a room to meet with me, I sat with them. I was this innocuous girl that they thought was still in high school doing a project. Anyways, so after 4 or so years with HAP, I transitioned with Accenture to WellPoint, which is Anthem today. But it was neat because I got to see how a health plan with 500,000 lives operates. And then I got to experience how one with 34 million lives operates, which was pretty cool. Wow. And that was in 2005, and health plans had begun launching CDHP products. Accenture was helping WellPoint get their member and provider portals ready for like a January 1, 2006 launch. And I worked on the member portal side. So then at that point, I had moved from Detroit to Atlanta, and it was in 2007 that I had decided to pursue graduate studies. And I went to the Owen Graduate School of Management at Vanderbilt University. I completed my MBA with a healthcare specialization there. And while I was in business school, I was really interested to see what it was like to work for a large healthcare company. I had this opportunity in consulting, on the payer side, but I was still consulting. Right. I wanted to see what it was like to work at a healthcare company. So I had internship offers from J&J and McKesson, and I decided to spend the summer of 2008 at McKesson in San Francisco at their headquarters. And it was a great summer. I learned a lot about drug distribution, which, obviously is an essential part of healthcare, but it's a really well-oiled machine. And I wanted to be at a healthcare company driving innovation. And that's how I ended up at Cerner Corporation, which was at the intersection of healthcare and technology, an intersection ripe for innovation and disruption, especially in 2009. Yeah. And I joined Cerner as part of their executive development program. So I did several rotations in the summer and fall of 2009. Actually, my first one was in HR. And I thought, oh, great. Like I took 2 HOP classes in grad school. I was
going to say, how did you get into HR?
This could be a colossal fail. That's what I thought. But it ended up being really great. And then that fall of 2009, I was invited to participate in Think Week with Cerner's CEO and exec cabinet, which is Think Week was actually longer than a week, but it was strategic planning for the following year. And like talk about executive development, that was really neat. So then fast forward to January 2010, I began a role at the Tiger Institute for Health Innovation, which was a newly formed public-private alliance between the University of Missouri and Cerner. And I did lots of population health kind of work, broad work, and trying to set up this. It was basically a startup at the time. I traveled to Columbia from like January of 2010 through May ish. And then in around July of 2020, that's when I assumed my role in benefits within the HR organization. So
while you were in Columbia, did you have, I mean, were you looking at healthcare types of activity, or was it more of like an ops type role? I'm so curious. I'm always curious about international healthcare.
Yeah, I worked for it was they had a joint CEO for the Tiger Institute. And basically it was how you brought a big university and a privately held company could come together to do innovative things, whether that be research together, whether that be things within technology. And so these were the early stages. So it was kind of figuring out how we would operate, within this joint realm. So yeah, it was neat and it was different. So it was fun. But so then at that point, then I transitioned into benefits, and I had I for the course of the next 10 years, I had responsibility for worldwide benefits, our wellness programming, wellness and well-being, and then the operation of our fitness centers, which we insourced. And that grew in that time from 1 to 5. That grew substantially too. And our team was really unique. I partnered and worked really closely strategically with our chief medical officer at Cerner, and he had responsibility for our on-site clinics and pharmacies and clinical oversight over our medical plans and wellness programs. So we had a really good alignment, and my team and his clinical team then worked in concert to build many in-house programs and services, and then bring them to life for our associates and their families. So we had a really unique structure that I think helped us in many ways.
So you were running a little bit of an innovation shop, Skunkworks, inside of employer benefits.
Yeah.
Awesome.
Yeah.
Is that I mean, that's really rare. Was that something that was kind of always done at Cerner because you're sort of in healthcare, or was it something that sort of developed organically?
I think it was something that developed organically. I think I was really lucky. I was lucky to lead benefits at a healthcare company. And because our executive leadership team was very in tune with our benefit strategy. Our CEO cared about what was being done.
I'm going to say too, just a lot of people don't share that. A lot of people say, man, it's way harder, unnecessarily so, to lead healthcare inside a healthcare company. I'm curious keep telling me about this though, because it worked out really well for you.
It worked out really well because it was viewed as a strategic asset for our company. And I was tasked with pushing the boundaries in terms of progressive benefit design.
Awesome.
So we were aligned very well, and we believed corporately that the words health and care should be separated. You often see it as one word. And we philosophically felt that it should be separated because at a societal level, there's too much of an emphasis on reactive sick care and not enough on proactive health. And so it was our desire to move upstream towards health as a company. But then that same philosophy then cascaded down to all of our programs and services for our associates and their families. So it was really nice for my team because we saw how our work aligned to Cerner's overall mission as a company. That was, and that's really nice when it cascades down.
No, correct. How did you?
But I was going to say, our team. So we were viewed as a living lab, and we were given the latitude to try and test new concepts, knowing that some might work and some might not. Our chief of staff, who our chief medical officer reported up through. I reported up through our chief people officer, but he gave us the permission to fail fast. So we were given that latitude to test things, knowing that we might have some successes and we might have some things that just don't work for whatever reason at the time.
Oh, I love that. And having that understanding preemptively has to reduce the cortisol load that you sort of are carrying all the time, knowing, hey, it's okay to try something, and that you can sort of step into the unknown a little bit, and that's something you can get excited about, not just be filled with trepidation.
Yeah, no, absolutely. Like we were expected to try new things. And so
Yeah.
that's a really cool culture to be a part of. Honestly, it was really fun. We had a lot of fun and we did a lot of good things for a lot of people around the world. And that's pretty awesome.
Hey everyone, now for a quick message from our sponsor.
Hey Dad, have you seen my PlayStation?
People who work for companies just like yours are desperate for any way to pay their medical debt. Support your employees by giving them 100% medical coverage with Catalyze Health.
Some people who work inside of big healthcare companies experience tension where people in other departments, because everybody in the organization knows about healthcare, you're not like the special SME. Whereas, if you're in a big trucking company, like your benefits person is probably as good on healthcare as anybody, right?
Yeah.
But if you're inside a healthcare system, everybody's an expert, and every single one of your members is an expert as well. I mean, it's sort of the stakes are raised. But a lot of them will say, hey, we're working on products in all these other areas, and they kind of foist those onto the benefits team. I'm sure that kind of thing was happening. What is it that made it, how did you handle that, and how did you turn that into a win? And maybe it was just really collaborative, so it wasn't that big a deal.
Yeah, it was. There were times when people so we were given the latitude to approach our business, like our benefits business, in a capacity where we were making decisions that were best for our members. And so there would be times when people would be like, hey, we think you should do a deal with X, Y, and Z because it makes sense for us corporately, and like not do the proper vetting and so forth. And it always rubbed us the wrong way. And we always had the leadership purview team, saying, no, that's not the way we do business in benefits. For selecting benefits, we would always take a very unbiased view and really try to make decisions for our team. The other thing I would say is that we had a lot of conspiracy theorists. We had all of these engineers who build the EMR. And so I should tell a little story about how we got to the place where we did, because it didn't happen overnight. But maybe I'll start there. So Neil Patterson was one of Cerner's co-founders, and he was also our CEO at the time. And he had this bold idea. He believed, it was because of Neil, he believed that if we could bring more of our operations and data in-house and have greater transparency and influence on the patient experience and quality of care, that we could have a profound impact on health and care delivery and outcomes. So it was because of Neil and his vision and his foresight. So back in the fall of 2005, the benefits team at the time was reviewing what the next year's increase, what the plan would look like in the next year's increase. And he said, let's fire the TPA, let's stand up our own TPA and begin adjudicating our own claims. So this is September of 2005. And so it's no small feat to stand up a TPA in 3+ months.
In 3 months? I wasn't paying close enough attention right there.
Yeah, it was that fall meeting, like that September meeting.
It was like, hey, in the next 90 days, we're now at TPA. That's bonkers. Okay, keep going.
Yeah, it's bonkers. And he also said that we would build our first on-site clinic at our world headquarters campus. And that opened in 2006 as well. So 2006 was this pivotal year. We became self-administered in addition to already being self-insured. And we began operating our own clinic, which is all in-source. They were all Cerner associates. And then 2007 was when we went full replacement high deductible plan. So we were really early movers in being full replacement as well. Because
nobody was doing on-site clinics back, like 2005 for an on-site clinic is super early.
Super early, yeah.
Okay, keep going.
Okay,
so like you guys are very early on all of this. Very early,
yeah. And so like when I think about like our biggest success, like it was really based on our macro vision. So 2006 was pivotal, right? And we made a lot of big bets, and things kind of progressed for the next several years. We made a lot of investment in capital assets. And then I joined the team in 2010. And that was also the year that Cerner was pivoting as a company from being known as a healthcare IT company to a healthcare company. And we changed our mission statement to contribute to the systemic improvement of healthcare delivery and the health of communities. And we believed that our associates and our families were the first community. And I mentioned how we had this living lab, our own R&D shop. And so we could
Right.
try and test concepts, and some of them could, with a hope that maybe some of them could commercialize. And so in 2010, we really began to think about the strategy that wrappers around these capital investments. And it really was three-pronged. So our consumer-driven health plan, which at the end of the day, the health plan is really your vehicle for driving behavior change, right? And then our services, both on-site and virtual, in terms of, and it grew as we grew over like the next decade from 2010. We had, at the time in 2010, we had a lot of lives concentrated in one place. So, from an on-site, we had clinics and pharmacies, fitness centers, cafes, but then we had to really grow the virtual footprint over the next decade as we grew. And then we had many programs. And so when you think about it, Lee, the way that I always like to talk about it is what we had really done is created our own health economy, right? We had all of the key stakeholders in a health economy. We had all of the providers who were salaried associates of Cerner. We had all of our members, everyone on our health plan. And
Now,
we
those providers, that's primary care.
Primary care.
You didn't own like surgical centers, though.
No,
Okay.
right. But that's funny.
But primary care is the first, like that's the front door, that's the start. And if you manage
Yeah.
it really well, you can wipe out half of the stuff that goes downstream anyway.
Exactly.
So,
Yeah. And so we did, and we had health coaches, and they worked in a care team model. So we had behavioral therapists, and we had chiro, and we had dietitians, and we had all of those as part of the broader care team. And then working in concert. So when you think about health and care, like our clinics really anchored the care side, our fitness centers anchored the health. And then we had all these programs and services that span that continuum between health and care. So it really all anchored in that core philosophy of separating health and care. And so in this health economy, it was our goal to realign the otherwise perverse incentives in the US healthcare system amongst these three stakeholders to create good providers of health and care and good consumers of health and care. That was our goal. And it was all of these aspects working together that really helped us to bend the cost curve. It wasn't just one thing. It's like we used to talk about it as like a stew. When you're making a stew, like the great broth isn't just because you have, potato, like beef or potatoes. It's because you have like all the vegetables. And it was similar in this regard. Like we had strong outcomes, and we were able to have a declining trend from 2009 to 2013. And we attribute it to what we were doing at the aggregate level, because it's really hard to piece out one thing or another.
That's outstanding. What percentage of your associates, because you guys had over 20,000 people on the plan.
Yeah.
What percentage of them were able to flow through the ecosystem over which you had direct control?
That's a good question. And I don't know, I don't have all my stats anymore.
No, you're okay. More than half or less
more than half. I want to say
more
like,
okay.
Like, gosh, probably, well, I don't know the stat, well over half were able to use our on-site clinics.
Interesting.
And then we had like all our days supplied filled through our on-site pharmacies. We had really high percentage there, because we were a first dollar plan that pharmacy and medical contributed towards your deductible. And so people could choose whether to fill their scripts at it was all choice, very consumer driven. You could choose where to seek your care and where to fill scripts. Should you choose to use one of our pharmacies, then you were able to get a 20 to 90% discount on drugs. And that causes people to, make different decisions. And so we had a very high fill rate, and you didn't have to you could fill any scripts there from outside providers because we were able to purchase the drugs directly from the distributor and then pass those savings on to the member and ultimately the plan.
So unpacking this, our constituents we have the families who are on your health plan. They're the consumers of health and care. You also have really advanced primary care. Was it in one location, or did you have a few around town?
We had three. Yeah, we had three, and then ultimately four in the Kansas City metro. And then actually we opened up one in Bangalore, India in 2016. So we had we opened up a clinic there where we were doing team care, primary care. We really talk about like really resetting expectations. We really did that in India. Yeah, we did.
Wow,
It was really
okay.
cool. Yeah, really cool what we did there.
And so that's primary care. You had probably basic imaging, I'm guessing, like
No, no
x-rays and things like
imaging.
no
No,
imaging. Okay.
we never did imaging, but we had diagnostic imaging centers is a large imaging
Mhm.
conglomerate, I guess, in Kansas City. And
Sure.
we had established where like they would send the images over to our docs in like really short order. So it was a very kind of tight experience.
You had
with
a
them.
direct contract there.
Yeah, I don't know if we actually even had a direct contract. I think that they just were, the way they operated was really efficient. I don't know. I don't know if we actually had a direct contract with them.
Wow. But either way, that's,
Yeah,
I mean,
it was, but it
you
worked out
certainly had
really well.
a
And we
gentle
didn't need
person's
imaging.
agreement right there.
Yeah,
That's
yeah.
fine. Okay.
Yeah,
So,
I don't remember if we actually did.
and then you owned your own pharmacy, and was
Mhm.
it able to mail also, or did people
No, we
have to
weren't.
come in?
We never were able to do mail order.
Okay.
No.
Okay. That's
Yeah.
okay. So but people would come into the pharmacy and you get drugs nearly free,
Yeah,
which
for
is,
really good
that's
discount. Yeah,
it's great benefit.
yeah.
And then I know you had infusion, you had, I think, direct contracts for infusions there in town as well. So you could kind of
Mhm.
control high cost specialty and other
Yeah.
therapies.
And create a better experience, for people
Oh,
that are
yeah.
in infusion. Yep.
Um,
And to be able to do it on, at times of day that were more convenient for them.
yeah.
So
How
basically,
much
our
of-
guiding principles were always around highest quality and experience, and that we found that if you pivot and focus on those, that you'll have improved outcomes and reduced costs over time. Those were our guiding principles, and we thought about that a lot when we would, in the event that we did partner externally with a third partner, and there was certainly we did a lot in house, but we also picked partners wisely, and we always thought about it within those guiding principles.
That makes great. How do we know who's high quality? How would you guys answer that question?
We had a lot of success within our own four walls of how we, focus on experience and quality that we could control. And so over that course of time, one of our largest drivers of spend was maternity. And we knew
Yeah.
that we weren't going to be able to make an impact on maternity unless we were to like build a delivery center on site, which we knew we weren't going to do. So
Right.
we decided to put together an RFI and send it out into the community. We actually did two, one for providers and one for health systems, and we got nearly 100% responses. And we soon saw we needed to optimize and just focus on one. And so we just focused it on the health systems. And we focused our RFI around those pillars around quality, experience, outcomes, and cost. And we found that there were a lot of health systems, like there's a lot of things that we wanted, like we wanted a TDAP to be able to be administered to the member and to the support person that was there. And there's a lot of Gordian knots in healthcare with the way that health insurance plays a part in that. And that was for some facilities like, well, how would we make that work with reimbursement and so forth? And like, they just couldn't figure it out. And so we ultimately partnered with two facilities that were willing to roll up their sleeves and rethink the maternity experience with us for our members. And we put a value-based benefit design around that. So there's a lot of price variation for cesarean and natural births in any regional location. And we thought if we could negotiate the price just below the median, that we could have savings both for our member and for the provider. And so we created a value-based payment back to the provider based on the member satisfaction with upside and downside.
Wow.
So that was neat too. That was something that we did with two facilities in Kansas City. And then we did something similar with that with Bariatric, where we did another RFI. That one we did around like across the country with centers that had the NBS AQUIP, which is a national accreditation for bariatric centers. And we ultimately found one in Delaware that we partnered with. And that was our first. It was a little different from maternity. Maternity, you could go to one of our partners. We called them Cerner certified maternity partners, but you didn't have to. You could still go to an in-network provider. For bariatric, you had to go to our Cerner certified bariatric partner if you wanted care, and we paid for travel and so forth. That was another direct contract, Lee, if you will, that we did, and where you're trying to figure out, how you balance those aspects around quality and experience, and to really drive towards an outcome. Uh-oh.
You're good. I would imagine that it's tricky to get the quality information on, for instance, for bariatrics. Would you guys just get it from the facilities themselves, almost like kind of an RFP, or were you able to find independent sources?
We did do our own RFP, but we did a lot with that MBS EQUIP accreditation. So we only looked at, which is that like national accreditation for bariatric centers. So we only selected, we only asked those that had that to respond. And for that one was a little different from our maternity one. Our maternity one, we asked non-Cerner clients to respond. By the time we had gotten to bariatric, we were looking for those that were users of Healthy Intent, which was a proprietary platform that sat on top of the EMR, and we were wanting that to be part of it. So for that, it was Cerner clients that we asked, and then we landed on one.
What do you think, if you look back over sort of the decade or so that you were working this, you guys had some incredible results. If you were to name the 1, 2, or 3 kind of the pinnacle, kind of pivotal wins that you think like those were the big things that had a lot of impact, which ones would you identify?
Well, and again, it's hard because we did so many.
That was the stew.
It's
Lee,
the
it's not the steak or the potatoes or the carrots. It was sort of
the aggregate. Like in those years when we had big substantial decreases, like one year we renegotiated our because we were self-administered, right? So we rented a provider network, and then we would augment with direct contracts. And one year we renegotiated that provider contract, and that was, several million in savings. And so that had a big impact. And looking at, your PBM contracts and doing, so it's definitely not, it was looking everywhere and seeing where you could wring the excess from the washcloth, if you will. I really think it was everything we did at the aggregate level that led to those outcomes.
It's a process, not a destination. It was, you were always being vigilant.
Yes.
You were always trying new things. Mm-hmm. You never sort of rested on your laurels. You were innovating constantly, and the accumulated effect of everything that kept going in is what mattered.
And nothing operates in a vacuum. Like I always would say that there's like, your population is changing, right? We had some big acquisitions that changed what our demographic looked like. You never know what's happening kind of at the regulatory level, right? That you have that impact. And then the third thing is what's happening just within healthcare broadly. And so all three of those make it so that you can't operate in a vacuum. Like everything is ever changing on those three spheres. And so you can't rest on your laurels. And over the course of that time, when we had that negative trend for it was our total pay PMPM that we looked at. And we knew we wouldn't be negative forever, but it allowed us to compound that savings year over year, and it allowed us to invest in those years, and it allowed us to be positioned well below where we would have been had we done nothing. And so, it was definitely advantageous, and it was fun to do it inside an organization that really cared about it and that empowered us to push the boundaries. So
some people get terrified about like, oh, what if I try something and it goes sideways? Thinking about everything that could go bad, because when you're trying stuff that is new, some of it doesn't always work. Tell me, in an attempt to sort of normalize that a little bit, tell us about some of the swings that that weren't hits, and how you made sure that you were okay and that the organization was, and how did you de-risk that?
Yeah, some things, one thing that was kind of interesting from when we went live with bariatric, and it was a travel program, our physicians in our on-site clinic were really there was a lot of tension with them after
Oh,
we went
really?
live. Yeah, they and we had several physicians that were part of the clinic that were part of the planning, but not everybody can be part of, design and planning. And there was
Right.
tension afterwards around how to do the follow-up between the facility in Delaware and our on-site clinics. And so that was one example where you're like, wow, I would never have expected that. And
Wow.
and so you just sometimes, you never know. Then there's things that like we wanted to do, but just we couldn't figure out. So we always were curious around the concept of food as medicine and being able to prescribe food out of our on-site clinics. And food
Right.
isn't broadly considered a qualified medical expense. And so we couldn't figure out, we never could figure out how to make it a pre-tax benefit. And honestly, like
Mhm.
we all thought this would have been a really cool experiment, in our living lab, but without it being funded by the
Mhm.
health plan, we weren't able to finance it or figure out a way how to finance it. And we spent a lot of time
Mm.
thinking about it, and we had a lot of conversations with legal and third parties, but we were never able to swing it,
Oh.
unfortunately. So there's some things that like are cool and we wanted to experiment with,
Mm.
but we we couldn't swing it. And then there's other things that happen that like are still very successful, like the bariatric one, but that you run into some snafus with the broader team and rolling it out and differences of opinion. And
Yeah.
it's like how, but that in any organization you're going to have some of that in terms of how you work through things and different differences in opinion and so forth.
I have to wonder, so was it that there wasn't like good connectivity between the bariatric center and the doctor, so the physicians were worried about the patients, didn't know what was going on? Or was it that some of the physicians were like, I don't even think we should be offering bariatrics because
No, I think
I
most
think
of them were on board. I think it was the
yeah.
fact that the concern was that they weren't local, the doctors weren't local for like follow-up care and so forth, and that they were put in the middle. But they're their primary care doctors. So
Yeah.
and we respected, their perspectives, and we worked together with them to figure it out. But it's just an example of, there's in healthcare is complicated, right? And there's lots of different
Yeah.
perspectives, and it's being able to, hear both sides and hear all the sides, right? And then figure out, and sometimes it's more than just one or two, and then figure out how you can, get it to a place that's amenable to all. And which we did, and a lot of people have had success, but that comes up in healthcare, especially when you're
Absolutely.
trying to do something new that feels a little uncomfortable, and how do you figure that out? And we had data flowing, like that was nice as a Cerner, a facility powered by Cerner technology. And so on our clinics, we're obviously using Cerner technology. So we had like the data flow is not the issue. And we had a navigator, a bariatric navigator also that was working with all of our members as well. So we, it's continuing to fine tune and tweak, which is, I think, normal in anything. You have to fine tune and tweak. But those are some examples of things that maybe didn't, from a benefits hat, we from our team, we thought, what, like, we're doing this great thing for our members. And,
Yeah. Everybody get behind it. Come on.
Yeah.
What, I mean, one, sadly, maybe it's not sad, but there's a little bit of sadness is that you're not leading a benefits health plan right now, and you were so good at it for a long time.
Thanks.
But there's lots of other new people who are coming into these roles.
Yeah.
What advice, whether it's you giving advice to a younger self or just someone new who's transitioning into benefits, tell us the advice. What should we do to make sure that we have an impact and help to make influence on the system?
So one thing that I would say is that I never had actually ever considered a job in benefits before joining Cerner. So it turned out to be this great alignment to focus my passion and energy for improving population health, especially, I had responsibility for a $250 million health plan in the US and responsible for benefits in 25 countries around the world. Like that's having an impact on population health. And so I would say
Right.
one advice I would say is to keep an open mind. Like, you don't know where your journey is going to take you. And so I would definitely say keep an open mind. The second thing that I thought about a lot when I was in the role was, so when I was a student actually in grad school at Vanderbilt, one of my microeconomics professors, his name was Luke Frobe, he would start every class with a situation, and then he would go around the room asking 3 questions. Who's making the decisions? Do they have enough information to make those decisions? And are their incentives properly aligned? And I would tell
Wow.
my younger self or others coming into this role that you need to think about those 3 questions a lot when making decisions around plan design and benefit offerings, because incentives, we talk like, especially over the course of the decade that I led benefits at Cerner, like incentive-based wellness programs are really hot. But the real, and that's good to have, it's fine to have those, but the real backbone of how you drive behavior change is through your health plan. And you do need to think about, and I was the era of this full replacement, high deductible plan, and so
Sure.
how, who's making the decisions? Do they have enough information to make those decisions? In the early years of CDHP plans, people had no information. And so we
Right.
worked a lot on,
They had skin in the game, but they were, but they didn't know the rules and didn't have any visibility.
right. Yeah.
They
So
were
really
playing
bad.
blindfolded.
Yeah. Talk about, so incentive misalignment, like across the board. And so I've thought a lot about that. And those 3 questions, I think, are ones to think about. And I would tell my younger self or others new to the field to think about those questions.
Who's making the decision? Do they have the right information to make that decision? And they may think they do. I'm thinking about, patients. Many of them may think they have the right information. Yeah, I asked my mom and she told me the best place, right? Or
Right.
my neighbor told me that this is the good guy, so that I have the information now to make that decision. So you may have an actor who doesn't realize they don't have the right information for the decision. And then the incentive alignment is classically totally wrong in healthcare, where you have one person providing a service to another person who consumes it, and a third party, who pays for it, and for most employers, a fourth party who sort of orchestrates the meeting of parties 1 and 3. It's a giant cluster.
Completely perverse. Yeah, you got it.
So I want to talk about self-administration. When you say, your employer was self-administered, it's, for many people, it's like saying, we flew around in DeLoreans and we visited the future. I mean, it seems so far out there. I would love for you to sort of give us a little bit of a crash course on what it is, why it's good, and why we shouldn't be afraid of it, or should we?
Yeah, I think, I mean, the pros were that we were certainly, like, since our TPA was a wholly owned subsidiary of Cerner, we did achieve, like, our Neil Patterson, who was our co-founder and former CEO, we achieved his vision of having greater transparency and insights into our data. Like, that is a definite pro when there's no red tape, and arguing with a carrier to access your own data. That's like the biggest pro, right? You have more latitude, and you have to make sure,
data visibility, control.
Right. You're not fighting with anyone. If you want to send data to data warehouse, or, if it's a transparency company, something like that, like, there's no fighting in that regard. I mean, we had processes. Certainly we took privacy really seriously. And they were a third party, and, wholly owned subsidiary. But yes, they were part of Cerner. So we were aligned in that regard. I think the cons were that because it was a part of Cerner, the TPA had to fight for the same funding that all the other orgs internally within Cerner, had to fight for as part of the annual planning. And so it didn't always get the funding that it needed in order to keep it leading edge. And so it was started with this grand vision. And really, so Neil, he like publicly stated how he wanted to get rid of insurance companies as they existed today. So he was very bold. And when he set up the TPA, he wanted real-time transactions, and he had a big vision. And I think ultimately what happened over the course of the years was that it needed more funding to be able to to achieve the vision, the initial vision.
Yeah.
And we were able to do lots of interesting things that we wouldn't have been able to do otherwise. I mean, certainly it was an important tool in our toolkit. But that was something that was a con for us, is that at the end of the day, it might not have gotten funding that it really needed to be, like, really out of the park in terms of achieving the vision.
Did it save you money being able to own your own
Yeah.
administration? How?
It did. I mean,
How is that?
we would get questioned around looking at the administrative side of running a TPA, and, versus if we were there. There were some things that we did that we knew, I do believe that it saved us money. But there were some things, like the network wasn't the best deal network for provider discounts, especially at the beginning.
Sure.
And there was a lot of the provider market, Lee, like there was like PCAH, Beach Street, like there was all of that.
Yeah. PHCS. That's right.
Yeah. Consolidations.
That's right.
And so multi-plan ultimately ended up being multi-plan, right?
That's right.
So initially we had to make a decision on, do you go with the best network discounts, or do you go with someone that's going to allow you to do the things you want to do, like direct contract? And so we knew going in initially that we weren't going to have the best contracts, provider discounts. And we were okay with that because we wanted to be able to do other things. And then over the course of time, we were able to find other networks that had a little bit better discounts, and you still use, multi-plan when we needed to for wrapper networks and so forth.
Sure.
But there's trade-offs, right? There's trade-offs. And we also commercialized it. But the network is always something. So we did have some clients on the TPA, as well, external clients. We were the biggest client, but we did have some external ones as well. But the network is always kind of that key. It's like the key hook for an employer, and in the commercial side as well. So it was definitely interesting. I think the experience that our members had was top notch, and people don't realize it until it goes away, and then they see, and so we were, at the time, for many years, we were an HRA and FSA only plan. There was no HSA. And so they would automatically take the funds out of your FSA first and then your HRA. So like you didn't have to do anything, and you didn't have to apply any funds, or they did it all for you. And
wow.
And that was really nice from an experiential standpoint.
Everyone, now just a quick word from today's sponsor.
Lemonade for 50 cents. It's for a good cause.
This situation seems terrible, right? Well, what if I told you it actually happened in the United States in 2021? These are the families of people who work for companies just like yours. Give your employees 100% medical coverage with Catalyze Health.
What about benefit design? What were ways that you, I like to think that the benefit design is the language that an employer has, or is the voice of the employer to the marketplace. It tells us what we value and what we don't, and what we want our people to be able to do.
Yeah.
Tell me about how you approach the benefit design strategy to make stuff that people loved.
Yeah, I mean, that's a great question. I mean, how do we design anything that people love? In my mind, it's designing a great high quality experience. It's removing friction and waste. In healthcare, it's putting the member and the physician at the center of decision making. And it's aligning incentives amongst the key stakeholders and empowering your members to be good consumers of health and care with curated information. I mean, I really think that that's what makes an experience that people love. And I think, what's also interesting is, I think when people think about, do you have quote unquote good benefits? Most people don't know about what benefits they really have until suddenly something happens and they need to utilize them. And I think most people use a proxy for good benefits as like what they pay for them. Are they expensive or not? And you don't really start to think about it until you're an actual user of it. And I think that another thing that benefits directors such as myself, like communication is really hard. And, you have a lot of programs and you spray them out there and you pray they find it. And it is hard. It's hard because people are busy. They're not always paying attention. So, but I think if you have those
super hard. Did you
components,
find anything that could kind of break through, or did you have any experiences or strategies that worked really well in that regard?
I mean, yeah, that's like ultimately everything that we tried to do was around high quality experience, removing friction and waste. We really tried to, like, especially in our on-site clinics and with partners, how do you put the member and the physician at the center of decision making? And then how are you aligning the incentives? I mean, I really think that those are people really like that. That feels really good. Like in our on-site clinic, we removed the waiting room. There was no need to have a waiting room if you remove waste of waiting rooms, right? That's just wasteful time. So if you're able to redesign the experience and go right into a care suite and everything comes to you, you're not having to walk down the hall to the lab and different things like that. Like that's, you feel that and you're like, wow, I don't want to go to other, like, it sucks when I have to go to the pediatrician or the dermatologist and have to wait in a lobby for hours upon hours.
Right.
You feel that, and it makes an impact, and people like that. So, and actually,
what were
go ahead, Lee. Yeah, please.
Oh, and I was going to say what were the kind of the levers that you pulled to align incentives? Because classically, if a hospital earns more, you just made less.
Yeah.
And so sort of the deck is stacked against you for sure in aligning those incentives.
Yeah. I mean, the maternity example was a good one, right? With the value-based payment, I'm trying to, create an incentive that both the member would get, and they had a $500 deposit into their HRA account for doing something, and then the provider also had an upside payment. So like that's a perfect example of an aligned benefit. And that it took no extra dollars. It's just extra dollars in the system already there. So that's a really good example. I think also, like in the on-site clinic environment, where we weren't paying our providers in a fee-for-service manner. Similarly, our members, when they sought care at our on-site clinic, it was we covered 100% of professional services and in-house labs. So there was no fee-for-service happening at all. We were able to make a typical visit was 30 minutes, and a typical annual exam, like your annual physical, was 50. So it was our goal that you go in and the providers were aligned, right? Because they weren't being compensated on a fee for service. They were being compensated to talk about the whole member. So like typically in primary care, you might come in for a back pain, but also maybe your mother-in-law is bothering you, and you've had a headache for 3 weeks, and like, so you might have to come back to like talk about those other things. But in our model, like it was meant that you talk about everything that's going on with you. It's not just like 7 minutes for this and then make another appointment to talk about. So that's another example of aligned incentives that we purposely, from a plan design perspective, designed it that way to have alignment amongst the key stakeholders.
I love that so much.
Yeah.
You were one of the earliest pioneers in the fertility space. A lot of employers want to offer this, but man, look at the price tag and it seems expensive. How did you, especially that early on, how in the world did you figure out kind of an ROI calculation around that?
Yeah, it was a hard one. There were 3 things that our members had been consistently asking for over the years. They had asked for gender affirming surgery, for fertility and family building benefits, and for bariatric surgery. And I'm proud to say that at the completion of my tenure, we were able to offer all 3 of those to our members. So that was pretty cool. But we didn't offer any coverage for fertility up until 2017. We only covered the underlying diagnosis, and we didn't cover anything else. And so it wasn't until 2016 that we had learned about Progyny, which at the time was an early stage company that was looking to transform health and care, but specifically within the fertility space.
Right.
And their approach really aligned well to our guiding principles that I've talked about a lot now, right? Highest quality and member experience. And they approached it by looking at how they could align the incentives, removing friction and waste. So that all aligned really well to our guiding principles. And they did something first of kind. So first they created a high performance network of reproductive endocrinologists. So that didn't previously exist. They paired that with this innovative, flexible, evidence-based plan design that's equitable for all people trying to build a family. There's a lot of inequities in typical plan designs that have been introduced over the years, where like there are things like where you have to maybe prove that you have infertility, or you have to, try to have intercourse for 6 to 12 months before coverage will kick in. And that's really discriminatory against same-sex couples and so forth, or people that are, wanting to have a child, single by choice. And so they really tried to design something that was equitable for all. They embed medical and pharmacy coverage to ensure that full cycles of care are covered, which is important. Because in a cap, like a coverage cap type of model, you could run out of dollars during a cycle. And then you have to make cost-based decisions, which does not lead to strong outcomes. And then they wrap all of this with a best-in-class member experience. And so historically, right? So like fertility hasn't been covered by plans because it was deemed elective, right? And so then what happened is then the market commercialized and became extraordinarily expensive. So from a cost, just from a cost basis, most people aren't able to try to build a family because it's too expensive. So the market was really ripe for disruption, and Progyny seized on that opportunity. And so Cerner partnered with them in their second year of business. So we were early movers with them. And in doing so, we enabled hundreds of Cerner members to build their families that might otherwise have been unable to do so. And actually, Lee, so I was one of these lucky members to have this coverage. We put this all in place. Our leadership team and our chief medical officer were really impressed with how evidence-based it was and how it was really progressive and how they were thinking about, the alignment between the key stakeholders and so forth. And then I myself later that year in 2017 was diagnosed with infertility. And so then I used the benefit myself. And you don't always, as plan sponsors, you don't always use the benefits that you put in place. And so this is an example where I did. And because I experienced it from both a plan sponsor lens and a patient lens, I have a pretty solid understanding of how outcomes are often inhibited when patients have to make cost-based decisions. And there's just Progyny is removing that sort of perverse incentive design in their model. And so, so the other thing I would say, Lee, is that benefit plans that typically don't cover fertility treatments, such as ours, prior to 17, they usually always cover the resulting babies. So when you aren't covering fertility and members are self-paying and they maybe are taking a second mortgage out on their house in order to, or putting, tons of debt on credit cards and so forth, you're making cost-based decisions that are not necessarily evidence-based. And so the incentives are all out of whack, right? And you might make a decision that's not evidence-based. And so 1 year prior, we had quads that were on the plan, and each baby was over $1 million. And so multiples are a result, right? When you're not doing something that's evidence-based like that, you might have higher costs in your health plan, these, some big peaks. And by covering fertility treatments with a company like Progyny, you can achieve really strong outcomes while normalizing that spend in your actuals. And so that then is like a win-win for all. It's a win-win for the member and it's a win for the plan. And because you're actually helping to, you're normalizing the spend, you have control over it in a really, and in a way that's producing lots of babies for your members.
Better outcomes as well. Absolutely. No, I love that. And so now if anyone wanted to reach out to you or connect with you, what would be, I don't know if they can reach out through LinkedIn or something like that.
Yeah, definitely. Reach out to me on LinkedIn. Arielle Bogorad. And I'd be happy to talk to you. So I guess I should say that So over the course of my journey, I became pretty passionate about improving access to care for fertility and family building. And I really believed in Progyny's model because quite honestly, it changed my life. I likely wouldn't have my daughter if it wasn't for Cerner's coverage with Progyny. And so as of May 2022, I now an employee of Progyny, and I lead Progyny's employer market strategy. So,
oh, it's terrific. No,
Yeah.
well, I love the story, and really the fact that you were one of the early users of that solution, and now, you know, it's extremely common. A huge proportion of large employers are now covering fertility in one way or another. It's awesome to have seen that strategy sort of become realized, and I think is helping, you know, so many families across the country.
Yeah, many more now, but there's still definite room for improvement. Many people don't have coverage still. And so, there's definite room for improvement.
Oh, it's awesome. Well, this has been wonderful. Thank you so much for your time today. And thank you everyone for joining us. If you have a chance, if anybody you know might be able to benefit from this and is also working in benefits, please send a link to this episode. And in the meantime, we'll talk to you soon. Thanks for joining us here on Broken Benefits. Thanks for joining us on Broken Benefits. If you enjoyed today's episode, please subscribe to our YouTube channel or on your favorite podcasting platform. Also, please share today's show with a friend or colleague. It's free to do, and it helps us spread the message to as many people as possible. Until next time.